Hello, everyone. Welcome to the first in a series of webinars that NCCRED, the National Centre for Clinical Research in Emerging Drugs, is running together with St Vincent's Hospital here in Sydney and the National Drug and Alcohol Research Centre also here in Sydney. I'm Nadine Ezard. I'm the Director of the National Centre for Clinical Research in Emerging Drugs and also the Clinical Director of the Alcohol and Drug Service of St Vincent's Hospital in Sydney. And I'm really pleased to be here today in these extremely unusual times for us. And it's no secret that the entire health sector is facing a host of challenges. And we wanted to explore firsthand with other clinicians who are working in the alcohol and drug sector on how the COVID-19 response has impacted on our work and how we can take up some of the opportunities that this poses and also how we're dealing with some of the barriers that are also being posed. We're going to have, this is a multi-part series, and we'll have discussions with clinicians, with experts in telephone counselling, with consumers, with families and with other people that are involved in accessing drug treatment during this time. The first one today, we're very fortunate to have Liz Nock with us. She's a clinical psychologist. She's the senior psychologist in the stimulant treatment program at St Vincent's Hospital in Sydney. And she brings a wealth of knowledge. Her doctoral thesis was on therapeutic alliance in a dual diagnosis population, exploring her belief in the importance of successfully helping clients to feel positively aligned with their therapist, engaged and correctly heard in a therapy process. She has extensive experience with adults, adolescents, children and young families across a number of public health settings and non-government organisations in Australia and the United Kingdom. She worked on a specialist pilot program in Australia targeting emerging mental health, addiction and personality disorders. She gained a broad-reaching experience as a locum clinical psychologist in the UK National Health Service, the education system and family support services in London. Liz has contributed to the development and evaluation of psychological services and treatment programs for community mental health service, including our own at St Vincent's Hospital, where she's a critical part of the stimulant treatment program team. And she has a wealth of experience in working with people, particularly with stimulant use disorders and also their families. And I'm really pleased that Liz has agreed to do this first webinar with us. Before we go into our discussion, if you have any questions as we go, if you're looking at this now in live time and not looking at it later in record time, please use the Q&A button at the bottom of the screen and we can pick up those questions at the end or if there's time and relevance as we're going along, we'll answer them straight away. So I'll just get going with the first questions. And I just wonder, Liz, if you can tell us what models you bring to your work and how this is challenged or adapting to the COVID-19 situation, particularly as we're moving to more online and remote connection with our clients.
Yeah, well, I guess in drug and alcohol particularly, we talk a lot about client-centered work, and I'm acutely aware that that's never been so important. I think when, in times of, I guess we say crisis or change, word unprecedented gets used a lot, having a sense of, I guess, clear options, choice being most important, acknowledgement of limitations that might be coming with the current situation that we're dealing with, client-centered care, clients being at the core of making decisions about at least what they choose to take up of what we can offer, has probably never been so important. I think bringing that sense of control that we recognise is important in treatment all the time is particularly important now. It's something I'm just becoming aware of. I think this is obviously a very new process for all of us. Similarly, strengths-based practice, I mean, this is, I guess, a time when the people that we're working with are having to be more self-reliant than ever. In a way, we're in this together, but also everyone's sort of sitting in their own individual places, perhaps very much in physical isolation. Obviously, we talk about not being in social isolation, hopefully. So I find myself moving more and more to conversations around what actually are those individual strengths that a client can draw on. Again, it's something that we talk about all the time in the work that we do, but I find myself going back to it more and more while I'm talking to people on a phone who are sitting in at least physical isolation, perhaps. Obviously, we work with CBT a lot in substance use field. That's been quite an interesting one to adapt. In some ways, the structure that comes with CBT is really, really helpful. I've found that bringing structure into my telephone calls is one of the most helpful ways of actually recreating that therapeutic session environment. So with CBT obviously does work. Just the idea of setting an agenda, thinking about activities and plans, and ending with sort of a really clear, I guess, sort of maybe some sort of activity or a wrap up, homework task, that kind of thing, is a model that has worked really nicely for me anyway. To bring, to attempt to recreate what would happen in a room, on a telephone or on a video call. But then there's the fact that, the behavioural side of that, all the things that our clients are looking to change, there's lots that's been taken away. We're not able to have conversations about going out and making new plans and routines and trying something new that day or that week. So there's a lot of adapting. I think we're all doing really quickly there. So many of the I guess we're having values conversations, the things that we would usually get clients to go out and trial and test and step by step behaviourally have all been taken away from us. So we've got to be a lot more creative. And a lot of the time.
One of the things that I struggle with is so many clients that I speak with actually don't have internet, don't have access to telephones with a lot of credit, don't have access to a lot of data to do the telephone and video conferencing.
Yeah.
I wonder how that also impacts on your practice and how you adapt to to remote work.
Yeah. Look, I think from at STP here at St Vincent's, we started working with telephone contact to begin with, and it's a nice way of easing in, I think, to this type of contact with the client. But it's quite different to a video contact. There's some real benefits, I think, to being able to see someone. Again, when I talk about kind of replicating the therapeutic room, a session as much as we can, being able to eyeball each other gives some sense that we know what we're doing, that this is a therapy session. But gosh, I've had lots of problems with of course the lag, data issues. Even if something works a little bit, is it worth it if you're getting this kind of delayed lag when every moment in that conversation is obviously usually important? I think I've had a few really successful attempts myself where it's been, I felt settled, I felt grounded, I've been able to feel that by having a visual contact with someone that has sort of has maintained that integrity of the therapeutic session. But otherwise, to have to sort of jump to, look, let's go and talk on the phone instead because this isn't working, it's inevitable that changes the dynamic of the conversation you're having. So straight away, sometimes when we get to that, I find we're moving into maybe case management type conversations then, check-ins and sort of briefer support, because maybe technology hasn't always worked.
So you're saying that what you're actually doing in those sessions is shifting to sometimes more concrete kind of interactions. Are there other changes in the way that you're delivering your counselling sessions? Are you looking at more modularized approaches or?
Yeah. I think definitely, I guess there's two parts to that. On the one hand, you don't want to lose the therapeutic relationship and it's the flexibility that you want with that. But at the same time, as I said, that's sort of the more structured, perhaps cognitive behaviour therapy model. I find myself sending emails with worksheets before I speak to someone, or even during speaking to someone sometimes, which is actually a bit of a whole new experience for someone like myself who's not very good at walking into a session with resources. But I'm at a computer talking to someone and I can go, hey, that's right, I've got this resource over here, and I'm going to send it to you right now. We look at something together, we work on a worksheet together, and that kind of anchors what we're doing. I've done that more often on the phone at the moment. As I say, there's a lot going on when you're trying to coordinate a video call, when you're trying to make sense of what you're seeing, like you're trying to, I guess, get that same impact of a relationship and a connection with someone that you'd be having in a room. There's quite a lot to be thinking about all at once. And that's a big change I find in my focus. There's actually a lot more going on in the therapist's mind, trying to sort of juggle all those components of what you're doing to make this most effective. And some of them are really practical considerations, like is someone going to walk in the door, or is the person really in a place that's suitable enough for this? And should I say something if I don't think they are? Or is this feeling like a helpful way to have this conversation? And do I hold the same boundary that I might hold in a therapy, in a room? Or do I flex because I want to make sure I get to talk to this person?
So do you take the time at the start of the session to set the environment and check in on where they're at? Or
yeah, I mean, I think that's definitely the sort of if you've got a chance to structure your sessions with exactly that, perhaps an agenda. One of the hardest things about moving to not being in the same physical space with someone is that the physical contact that you have is a huge part of the relationship, the therapeutic relationship. Obviously, I mean, we're losing a massive number of non-verbal cues, and there's no way that seeing someone on a video makes up for all of the verbal cues that you lose. So, I mean, there's actually some suggestion. I've been talking to a lot of sort of clinicians about this lately. It actually might make things more complicated because you're seeing someone's movements, but you're not getting the cues that you're used to getting when you're in the same space as someone. So you're almost working in overdrive without knowing it to make sense of what's going on for the other person, and probably in turn they're doing the same for you. That's normal interaction. But so, I mean, I think there's a lot of difficulties that come with that. Some of the ways you might overcome it would be actually putting in, really structuring into your language and agreements with the person you're talking to of how you might communicate how they are, what's going on for them. And I think the use of, we use patient-reported outcome measures in our face-to-face sessions. And I think learning to find ways very much in conjunction with the person you're speaking with, it has to make sense to them, to kind of say, because I can't, I'm not in the room with you, let's find a way to kind of check in about how you are when we start this session. I mean, from a therapy perspective, I've been thinking a bit about using, strategies like, in anxiety management, we talk about subjective units of distress, but like how might a client describe to me if they're feeling okay or not feeling okay? Because I might need a bit more of that verbal information, and we probably need an agreement on how we're going to talk about that. We talk about window of tolerance when we work with our clients, helping them understand or sort of have a sense of what feels okay and what doesn't feel okay, and being able to communicate that to me verbally, but that's even more important to communicate it verbally when I don't get the same non-verbal cues. So I think in a perfect world, I'm aiming more and more to have a shared agreement, as obviously everything's individualized, but a shared agreement with the person I'm talking to about how we actually have, how we communicate that together, how I get a sense that I don't miss some important information about how they're going, how they're feeling at the moment, if the conversation is okay. Is there anything that needs to be done to sort of for safety or contain emotions, or is the conversation not working? I don't think I get it right all the time, but I'm a lot more likely to get my guesses around that right when I'm in a room with someone.
I mean, you've spoken a lot about the barriers of moving to remote contact, but are there opportunities that you see as well? There might be less of a threshold for people to come forward for treatment.
I mean, even on the topic of sort of that client-centered approach and asking and thinking about asking, I don't think it's ever bad for us to be reminded to not make assumptions. I mean, obviously there's a lot in that non-verbal stuff which is important, but it's not a bad thing to be required to develop a language that works, or a shared language with someone you're working with. I think that's a real strength. I mean, I think everything is very individualized, of course, and that's often the answer everyone will give. Some people will say the relationship doesn't work so well, but online, whether it be phone or visual. But I've definitely anecdotally heard a lot of people working in this area say that, yeah, exactly as you say, it can feel a bit more comfortable. There's a slight protective barrier, and that conversations can be opened up, or at the very least that the conversation has changed. If it's someone that you've been working with for a while. I mean, that's a difference as well. It's going to be different for someone that you've had a pattern with for quite a while working as a therapist compared to meeting someone new via a phone contact. I had my first probably new contact with someone I've never met face to face this week. And it was via phone, not visual. So in a way, yeah, completely blindfolded. And it actually went quite well, and at the conclusion, although we did have the luxury, at the conclusion of that session, we agreed that this young person might come in and meet me face to face next, and then return to a telephone or video contact. For her, there was a sense of developing trust in the phone call, which was enough to then think about coming in to eyeball me, and it actually worked quite well.
And is that something you're also looking at? Is sort of mixed models of remote plus some face-to-face contact?
Yeah. I mean, obviously, we're thinking about Australia and COVID-19. We're in a bit of a holding pattern. We're preparing for the unknown in some ways, but it could be that we're in a situation where we couldn't see people face-to-face, where it wasn't an option. While it is potentially an option, given the challenges of assessing, let's say, risk, certain types of sort of obviously medical assessment, which wouldn't be me myself, but I think it's quite a nice opportunity to mix the two. And I think if we're thinking longer term for how we would keep doing this kind of work, I think there's a lot to be said for being able to see someone face to face, at least say every few weeks. And so long as you can develop a pattern like this, what I've talked about, there's sort of a structure to the way you do your phone or video contact, that then can be interspersed in between quite effectively. I think obviously as clinicians, we do think a lot about ensuring that we are sort of, I guess, assessing risk in an effective way, in a helpful way. And we've probably got quite a bit to learn still about how we do it if we weren't having any contact at all with someone face to face.
Yeah, I was going to ask about how you both assess risk, but also work with clients to plan for addressing their own risks that might have changed, both in terms of their exposures, but also how they're going to respond to them. So have there been any significant changes to how you do that in a remote way?
How we might support someone to respond differently. So how we might safety plan.
Working up a plan for their, if you're doing your usual risk planning, which often involves step-by-step approaches that maybe that's changed, the risks that person have changed, but also how they're going to respond at each level might have changed as well.
Yes. I mean, of course, I guess ironically in a way, a lot of the systems that we rely on are phone contacts for sort of out of hours and that sort of thing. So a lot of that remains the same. For just say I'm working with emotion regulation or sort of impulsive type behaviours, concern around sort of mental health, I probably found myself being a bit more creative and actually turning that into a strength. So again, trying to reframe the need that lots of people are in this situation together, even though we're all separate. I've found that people respond quite well to actually, like, here's this kind of unprecedented need to find creative ways to say, sort of regulate one's emotions or find distraction in really odd ways. And I think I've found myself going to distraction techniques, for example, that I would laugh at myself if I suggested them if we weren't in these times, because people would go, it's not going to help. And it's almost an opportunity to be a bit more creative with that and have it be accepted. And that's that idea of everyone being in this together to a point. I've personally had some really nice conversations with people about the difference that this has created of being in a situation that we're all in together, whether that be the client actually having concern for me, checking in and understanding that I'm working out how to do this at the, sort of on the run as well, or the idea that, yeah, like some of those things that aren't available to us right now, it's not because of anyone's sort of, no one intended this to happen, there wasn't someone's blame or something that's gone wrong. And I found that really helpful to actually drive a bit of more sort of positive reframes and a willingness to accept and give other things a go.
So the commonality of shared experience.
Yeah.
Right. And what about people's specific anxieties around COVID and around their risk of exposure, or around what's going to happen in terms of the economy, or what's going to happen post-COVID, and the uncertainty of that? Have you got any specific tips to share with us, or experiences on how to communicate that uncertainty to clients around what's happening with the services we're going to be delivering in COVID? We don't know, or what's happening to them going forward. Are there ways we can do this that makes people less anxious rather than more anxious?
I mean, I'm thinking about the reality of the uncertainty. I would always start with clear, open information about what we do know. When it comes to our service structure, for example, and I would say we've been changing bit by bit over the weeks as we've had information and got more of a sense. So the information we have perhaps given to clients has changed about our availability, or how that will look, or our type of contact. So, you know, I think the best way to allay anxiety is always to start with what we do know, and then to perhaps be really clear about the bits that we're not sure about, the possible outcomes that we don't have a sense of control over. I mean, the funny thing about that is that brings us straight back to cognition, which is often the only thing we do have control over in these situations. And again, it sort of allows a nice therapeutic reframe there, that while there's lots of unknowns, what we can potentially change or manage or control or accept is how we're responding to a situation. And again, the shared nature of that is actually quite positive.
Yeah. And we've been talking about clients, but what about your colleagues, or you as a group? What are the added stresses, and how are you dealing with them collectively as clinicians?
Really, one of the first things that comes to my mind is that it has been quite I've found coming to work quite tiring. And I think that's probably a feature of trying to adapt myself. And as I say, the more I think about it, the more I think that the phone contacts that we're having, while in theory they probably do take up anything up to 15 to 30 minutes less time often than having someone walk in the door. By the time you've sort of done everything that you do, it's not that hard to, once you're good to go in your office, time might be less. But actually I'm finding myself probably a bit more exhausted after those sessions. And I think that's got a bit to do with the fact that we're attending to so much at once. It's already quite an emotional burden working as a counsellor, and there's a lot more in our mind to hold on to, and as I say, the lack of sort of the non-verbal cues and trying to make sense of what's going on. So I'm finding myself tired. I mean, the other thing in my role is that all of us staff are similar, you know, exactly the same as the people that we look to support, and we have different, I guess, needs as well, and everyone responds in really different ways to a situation like this, and that's completely normal. So where someone might have their own anxiety in a workplace, another staff member might be completely flippant about something, and that's sort of recognizing that difference in the way we respond while we're being asked to continue and wanting to continue as sort of as services.
But you're still coming into work, but some of our colleagues across the state and the country actually working from home, delivering from home. That comes with its own challenges as well.
Yeah, I mean, we've sort of moved to that in the last few weeks here at St Vincent's, and I mean, isolation to begin with was the first thing. worked really hard to try and factor in a sort of a daily plan where we're having at least twice daily contact with our colleagues, because working from home in this field and not talking to anyone else all day could come with a lot of challenges. Again, obviously we're wanting to ensure that people, are both clients and staff members, are feeling emotionally supported. It's a luxury to have a team around you, I think, in a setting like this. I actually am not sure how I would go working as a sole practitioner and moving to a completely isolated space. I think in that situation, keeping regular contact with colleagues in some way or another would be really, really essential. And I find us all saying, you know, when this is over, there's a sense of limbo, but also having to really get in and respond and do things a bit differently right now. And that limbo feeling is a bit strange.
But we can flip it around, I guess, and say it is introducing new ways of doing things that maybe we carry forward as well, perhaps. And what about group models? Can you do group? What have you got any experience of adapting groups to the virtual space as well?
I know that a lot of, I've obviously heard that smart groups have gone online, and we've got some of our clients are using that. We're looking to go down that path here. I guess my thoughts would be, first up, it's a brilliant idea because the big thing that we're missing a lot of the time is the connection, and the thing that our clients are missing is that connection with others of some sort or another. And so the potential to bring people together and share experiences sort of once a week has the potential to make a really big difference. And I think the same things apply as I've talked about in individual therapy. You'd want to be really conscious of how you would keep people safe, who's attending. And the other thing I didn't mention in individual work was knowing where the person you're speaking to is physically. I mean, I think that's really, really key to setting up your session before you get going. Where actually are they residing? You know, I think it's better to ask that before than wish you'd asked it later on. When we're not sure if someone is not feeling contained or safe, I'd really like to know where they are. And so exactly the same thing applies for a group model. I'd like to, you know, I'm going to want to know who's there and where they are for keeping everyone safe. And I think all the same group rules and norms would apply as well. But groups usually sort of have two intended purposes. Some are more didactic, that sort of skills structured model, and others are more of that interpersonal shared support. I think they've both got validity in a telehealth setting. It would be really important to be clear what your purpose is. And I'm interested in moving, we do a 4-session sort of basic drug and alcohol skills group in our outpatient service here at St Vincent's. And I'm really quite interested in trying to adapt that to a group setting, because it feels like it brings a little bit of that, as I say, that structure. That's a CBT, DBT type based group, brings a bit of the structure that I guess helps you maintain that sense that you're in a group setting, that you're in a therapy process. It has enough sort of interactive components where people could perhaps be joining on a Zoom call such as this, or telehealth, obviously models, and be interacting and practicing tasks and being encouraged to go away and practice tasks and talking about that together. So I think that's got some real potential. It's obviously a really, really different model to perhaps sort of MA model online, which is a shared support idea, or even SMART, which might be sort of a check-in around anyone who attends and how everyone's feeling. So they're really quite different. And yeah, I'm quite interested in seeing how we go with quite a structured sort of skills type group for our guys who are definitely keen for, when everyone's looking for things to sort of factor into their schedules, and as I say, being as creative as possible. So
great. I've just got a question from somebody in the audience who you may not be able to answer this, and if you can't, we'll get the answer out there more informed way. But they're saying that there are apparently restrictions in New South Wales health policy in having email contact with patients. And this person is finding it very helpful and doesn't want to stop it. So I would like to know kind of what
I don't know about formal restrictions. I know that in our service we have our own, I guess, recommended practice. We have a shared service email, and we, up to this point, it's always been our common practice that if we need to email patients, we do that from the shared email, and that's obviously from the sake of keeping not missing something. That's something that's checked all the time. It's not dependent on one person responding to an email, and that's obviously, I would guess, why a rule like that might exist. We don't want to miss really important information dependent on one clinician being away that day. But I personally think this is probably one of those times when we might have to, I don't know I'm not sure what the sort of, whether the guidelines would stand on that, but if we're now doing telehealth contacts with clients, it feels really key that we find some new ways of making sure we can get information to them quickly. And exactly the same, I saw an email chain through our email just this morning, release of informations. No one's seeing anyone face to face. What now passes for a release of information form to allow me to speak to someone else on a patient's behalf? And I'm not sure of the answer to that yet. I was actually going to follow it up after this.
The other thing I think, just in general, in my experience with the email, with the discussions we've had about email contacts, is about having an automatic out of office thing too, so that people are aware that it's not responded to after hours.
Yeah.
And then having individual discussions with clients that prefer to send long monologues in the middle of the night, but then are not available for the routine scheduled appointments. So that's anti-therapeutic. So I think you need to manage it a little bit on an individual basis as well.
Yeah.
So,
yes. Yeah, absolutely.
Yeah. Just picking up on a couple of things. So those materials that Liz was mentioning just before about the structured group program, we're hoping to get that online for everyone to at least start a discussion about that. We will be sharing some other materials based on the topic of today's discussion about changing our practice as we move to more remote delivered care. In 2 weeks' time, we will be having another webinar specifically on micro skills for telephone delivered counselling with one of our expert telephone counsellors, and that, I think that will be a useful addition to some of the things we've discussed here about how to work in a way where all you have is your voice. So that will be an interesting one for us to follow up as well. And I guess I'd just like to thank Liz very, very much for taking the time out. I know it's a really busy time for you, so I do really appreciate that you've joined us today. And at least if we can't get the information, we'll start the discussion about ROIs and clients.
Great, thank you very much.
Thanks, Liz. Thank you everyone for joining today, and look forward to catching up again next week. All right.